Hello, I'm Vanja Douglas. I'm a neurohospitalist here at UCSF, and with these 4 modules, we're going to be talking about acute ischemic stroke. So we define stroke as the acute onset of a neurologic deficit that's referable to a cerebrovascular cause. And of all strokes, about 85% are ischemic in the United States, and 15% are hemorrhagic. Of those hemorrhagic strokes, about 3/4 are intraparenchymal hemorrhage, and then about 1/4 is subarachnoid hemorrhage. So today we'll be focusing on ischemic stroke, and we'll leave the hemorrhagic strokes aside. So let's focus now on the approach to acute ischemic stroke treatment. Stroke treatment kind of falls into 2 categories: how to manage the stroke in the hyperacute setting, and then how to deal with the stroke afterwards, which is more rehabilitation and secondary prevention. So for the next few minutes, let's talk about the hyperacute phase.
So fortunately, we live in a time where there are some treatments available to us for acute ischemic stroke, and they have the ability to remarkably improve a person's chance of having a good outcome after their stroke. The first treatment that's available is intravenous tissue plasminogen activator, or IV-TPA. That can be given to any patient with an acute ischemic stroke as long as they're presenting within 0 to 4.5 hours after onset of their stroke. So the randomized trial data shows that people who have an ischemic stroke and are treated with placebo have about a 26% chance of recovering with no disability, compared to a 39% chance of having no disability from their stroke if it was treated with TPA. It's a pretty significant clinical difference with a number needed to treat of about 7 to 7.5. So in addition to IV-TPA, since 2015, when there were 5 randomized trials that all showed that embolectomy was effective for acute ischemic stroke, we have that as an option for us as well. So embolectomy is when an interventional radiologist will thread a catheter through the femoral artery up to the occluded vessel in the brain or neck and then extract the clot. This is only available to patients who have large vessel occlusions, which account for about 20% of all ischemic strokes. Patients have to present within 0 to 6 hours, and the outcomes are pretty remarkable. In the randomized trials, if people presented within 0 to 4.5 hours, they still got IV-TPA, and that's important to remember, and then they were randomized to either embolectomy or no additional treatment. For those patients who did not get embolectomy, the level of independence after the stroke was between 19 and 40% in all these different trials, whereas if embolectomy was performed, the likelihood of independence went up to 33 to 71%. That's, again, a pretty big clinical difference with a number needed to treat ranging from 3 to about 7.5 for these different trials. Now, in early 2018, there were 2 clinical trials that were published that showed there's a subgroup of patients with large vessel occlusions that could be treated with embolectomy between 6 and 24 hours. Using perfusion imaging techniques, which is either with a CT or an MRI, you can estimate the amount of brain tissue that has actually infarcted and how much brain tissue is just ischemic. So that ischemic area around the infarcted area is what we call the penumbra. Now, these trials enrolled patients with large vessel occlusions who presented between 6 and 24 hours and who had a large ischemic penumbra based on this perfusion imaging. Doing an embolectomy in these patients took them from a 13 to 17% chance of independence to a 45 to 49% chance of independence. That is a number needed to treat of 3.1. This is a picture of the perfusion imaging from the Diffuse 3 paper in the New England Journal of Medicine, which was one of the randomized trials looking at embolectomy in that 6 to 24 hour time window. So I just wanted to show you this so it makes more sense. You can see the ischemic core here on the left side in purple. And all of this is most likely infarcted tissue. And then you have the ischemic penumbra over here in green, which is brain tissue at risk but not yet infarcted. So with embolectomy, perfusion to this green territory is restored, and then the brain there is saved. Without embolectomy, in most cases, that green area eventually also undergoes infarction, and then patients are left with significant disability. So now let's focus on how you deal with a patient who's coming into the ER and you think they might have had a stroke and they might be in this acute treatment window. So the first thing you want to establish is when the patient was last seen normal. The reason we focused on the last seen normal time is that this is the most accurate way to be sure that you know when the stroke started. It's hard to know exactly when a stroke started because patients can't always report to you when the stroke started. They might be aphasic, or oftentimes they're not even aware they had a stroke, so we always go back to the last time that somebody saw them normal to be absolutely sure. The next thing you do is a very abbreviated exam, and that's just to make sure that the deficits the patient has are consistent with a brain localization. Then, you go through a very brief history with the family, usually, about the past medical history and the medications, and that's mainly to make sure that there are no exclusions that would prohibit the patient from being eligible for TPA.
So the next thing that you're going to want to do is get the patient to the CT scanner. And usually we do a non-contrast head CT and a CT angiogram at the same time if we're in this acute treatment period. So the non-contrast head CT is really to tell whether or not the patient had an ischemic stroke or a hemorrhagic stroke. That's really the only way to tell the difference between those two types of strokes. With ischemic stroke, remember that it takes about 6 to 12 hours for ischemia to show up on a head CT. So usually in the acute ischemic stroke period, we expect the CAT scan to be normal. The CT angiogram is now kind of a crucial part of the workup of an acute ischemic stroke patient because of the opportunity to do embolectomy. So remember, 20% of patients are going to have a large vessel occlusion, and the CT angiogram will show that large vessel occlusion and will guide us towards moving that patient into the angio suite so that we can do an embolectomy. We'll also want to get labs, and the labs are sort of self-explanatory or common sense that you get in stroke. We are very concerned about the platelets and the coags, of course, because if it's a hemorrhagic stroke, you'll want to know what those are to fix them if necessary. And then we can't give TPA if the platelets are too low or if the coags are out of whack, so they need to be checked. Okay, so the last thing we need to talk about for acute ischemic stroke management is shifting gears a little bit, and that has to do with blood pressure. So we talk about this concept of permissive hypertension in ischemic stroke. And the idea is that if you have an ischemic stroke, the body has this natural reaction where the blood pressure goes up to deliver blood to the ischemic tissue. And we know from randomized trial data and from experience that if you lower the blood pressure pharmacologically in a stroke patient, then you can transform that ischemic tissue into infarct. So we want to let the body kind of do its thing and keep the blood pressure up in ischemic stroke. Right now, guidelines kind of say that you don't need to lower blood pressure unless it's above 220 systolic. The only caveat to that is if you're giving IV TPA, in which case the blood pressure does need to be lowered a little bit. The theory is that if the blood pressure is too high when you're giving TPA, then you could have a hemorrhagic transformation. So in all the randomized trials, and now the protocol is to make sure that the blood pressure is less than 185 over 110 if you're going to give IV TPA. You obviously don't want to lower it much more than that, but we usually give a small dose of labetalol or another antihypertensive to get the blood pressure just below that range before we can give IV TPA. Another question that often comes up then is how long do we treat with permissive hypertension? And that varies. There's no hard and fast rule about that. Most people say 24 to 48 to 72 hours, something along those lines. One important thing is to remember that we do want to start the patient eventually on a blood pressure medication, and it's always better to start that medication in the hospital as opposed to after discharge, because studies kind of suggest that people are more likely to continue taking medications that were started in the hospital. Okay, so that covers the acute treatment for ischemic stroke and how to approach these patients. You'll learn much more about the nuances of this on your clerkship as you see some of these patients.